Okay, good morning, everybody. Hello, everyone, and good morning. We're having a few technical issues. Just bear with me 1 second. Okay, so yes, we have a few technical issues. So apologies for those of you, there's a few pingings as everyone arrives, but hopefully everyone will turn up. So first of all, a warm welcome to our Bump2Baby and Me Forum. I'm Jo Boulding from Beta Technology in the UK. We are the partner in the Bump2Baby and Me project, and I'll be your host for today's discussion. For those of you who have not joined one of our forums before, Bump2Baby and Me is a 5-year project funded by the European research programme Horizon 2020 and Australia's National Health and Medical Research Council. It's delivered by an international consortium of partners, and the focus of the project is to undertake a randomised controlled trial to test a novel healthcare intervention during pregnancy and the first year after birth. The ultimate aim of the project is to provide policymakers, healthcare decision makers and health service commissioners with a cost-effective, evidence-based healthcare intervention to help prevent maternal and child diabetes. Throughout the project, these regular forum meetings will bring together policy and health stakeholders around a topic or challenge that's related to the project. And the topic for discussion today is the role of integrated digital healthcare in preventing gestational diabetes. We hope to not only raise awareness of the project, but also to gather stakeholder input, get to know each other and exchange information of mutual interest. Joining us today, we have international stakeholders representing academia, intermediary organisations and regional health representatives. But before I get started, I'd just like to run through a little bit of housekeeping. For our future reference, the webinar is being recorded and transcribed, and the recording will be publicly available after the event. Could all participants please remain muted unless invited to speak, but please do leave your cameras on if possible, especially if you are speaking. You'll be able to ask the speakers today some questions after the presentations are finished, and then we'll open up the floor for a more general discussion. If you'd like to ask a question, please use the chat function or raise hand emoji. And if you want to like any of the questions in the chat, if we get short of time, we can prioritise those that are most popular. And by all means, use the chat for any comments or observations. The aim is this event is meant to be interactive and informal, which of course is not easy at all when it's a virtual event, but please do use the session to raise any questions, share your experiences and acknowledge and introduce yourself to your fellow delegates. So today I'm very pleased to welcome 4 presenters from both the Bump2Baby and Me project and Irish and UK midwifery services. Each presenter brings different insights and knowledge related to today's topic. And firstly, I'd like to introduce you to our project coordinator, Professor Charlene O'Reilly from the University College Dublin. So thanks, Charlene, over to you.
Thanks very much, Joanna. So I'd like to kick off by starting to present on the overview of what is gestational diabetes. So gestational diabetes, for anybody who isn't aware, is where you have a rise in the level of glucose in pregnancy, and it basically falls under the term of having hyperglycemia within the period of when a woman is pregnant. So for those of you who aren't aware, I think this picture speaks volumes to the challenge that gestational diabetes presents to a woman during the period of pregnancy. So on the left, you will see a pregnancy unaffected by gestational diabetes. And on the right, you will see a mother who had gestational diabetes, but it wasn't managed well during that time. So it presents a big challenge to both the mother and the infant. So it's a leading cause of maternal mortality and can lead to things like preeclampsia and challenges in and around the time of delivery. So you can have a large for gestational age, as you can clearly see that the infant over on the right-hand side is very large for its actual age for when it was actually born. And it will lead to challenges around things for when the baby is born. So things like premature labor, stillbirth, and that baby, even though it is quite large, has potential for having low blood sugar around the time that it's born. And so babies born for large for gestational age, as they're called, have challenges later on in life potentially as well. And it marks them out as being at higher risk for chronic disease, as well as challenges during the time for when they're born. So in terms of what we know about gestational diabetes, these are sort of a quick summary of the facts for what we do know around gestational diabetes. In Ireland, about 1 in 8 women are at risk of developing gestational diabetes. And it really comes out of the blue for about the 7,000 Irish women that have it every year. In the National Maternity Hospital, where we're actually running the Bump2Baby and Me intervention, that is about 8,000 births a year, which means that about 20 newly diagnosed cases of gestational diabetes happen every week. In the case of globally, that figure is even more common. So it's about 1 in 7 births. And in some populations, that can even be half of that. So 1 in 4 women, for example, in Indigenous Australians, or maybe in populations like Thailand. So it marks a woman out for being at really high risk of developing type 2 diabetes in the intermediate period of about 5 to 10 years. And she has about 8 times the risk of a woman who didn't have gestational diabetes in her pregnancy. And obviously that risk can be increased compared to women who are of non-white European backgrounds, or those who are not in the overweight or obese categories in terms of their body mass index. One thing that we do know is that the rates of women entering pregnancy at higher BMIs is increasing. So for example, here in Ireland, 1 in 2, and also in the UK, we would say that 1 in 2 pregnancies are affected by higher BMIs. But we know that it's also not doom and gloom, that there is an effective treatment or management for women with gestational diabetes, and that is lifestyle modification through healthy eating and physical activity. So you can have a nearly 60% reduction in risk at 1 year, if you can introduce that risk modification, and that is sustained. So about 35% reduction in risk at 10 years for women who went through a risk reduction program. So there are other healthcare challenges, and no doubt Mary's going to talk about those, and I'm sure others are going to talk about them. There are things like screening variations, so different countries do screening differently in pregnancy. There's challenges around the way that screening is done. It's inconvenient for the mother, and the way with which we do the test, which is called an oral glucose tolerance test. And the cost of testing in pregnancy is actually quite high. For example, in Ireland, a woman has a big out-of-pocket expense if she doesn't have a medical card. It's about €25 a week for the testing strips at the moment. There's no national register in Ireland, so that if you have gestational diabetes, once you deliver, in essence, nobody knows that you've had gestational diabetes. So you don't get called back for any checks once you've had your baby. And so the continuity of care is a bit of a challenge. And similarly, during the COVID pandemic, we found that there was variations around the world in the way that screening changed, and also in this whole topic of around technology and digital innovation, we find that it brought to the forefront the way with which women took up challenges in around how they were using screening in pregnancy, and also testing in pregnancy. And again, that's probably going to be a nice topic that people are going to bring to the forefront. So just to highlight to everybody, the Bump2Baby and Me study, it's got a lot of partners, but the sites where we're actually doing the study is in Dublin, in Bristol in the UK, in Granada in Spain, and actually in Melbourne in Australia. As you can see there, the sites in Dublin are the National Maternity Hospital, Southmead Hospital in the UK, the Clinical University Hospital San Cilio in Granada, and Monash Health in Melbourne. And just as a quick outline to what the Bump2Baby and Me study is, you have those 4 sites. They're doing screening in pregnancy using a standardized screening tool that's validated based out of Australia, but it was validated in other countries to be shown to be a robust screening tool that's aligns well with other international screening tools, and it uses standardized metrics that are in most of the other screening tools in other countries, so easily collectible data. And if you score 3 or higher on that tool, you're invited to take part in the study, and that's at the first antenatal visit. Women were randomized and taken into the study. And then they either got the intervention, which is our digital intervention, which is the app with a personal health coach, and they took part in that for 18 months. And at 1 year postpartum, they were invited back in to come back in and give measurements, or they got usual care, which is standard care in all of the hospitals. So we screened an awful lot of women, as you can see there, and we had 857 take part in the study. And as you can see there, 432 roughly in each arm got either the intervention or usual care. And just to say that the final visits have commenced. We've got European participants finishing up in July 2023, and the Australian participants will be finishing in September 2023. And as you can see there, Dublin and all of the other sites have commenced their final visits, and that, as you can see, in terms of where the study is progressing, and that marker of the icon will tell you where we're up to. And we have had all of our babies born, which we're really excited about. We've over 700 Bump2Babies born, and we're looking forward to having our study results coming out in early 2024. So I'm going to hand back into the very capable hands of the next speaker.
Thank you, Charlene. That's a super introduction for us. Thank you very much. I'd now like to introduce Lois Meller, who is the Director of Midwifery at Doncaster and Bassetlaw NHS Trust in the UK. And she's going to give us an insight into some of the local maternity service challenges. So over to you, Lois. Thank you.
Thank you. Right, here we go. So, as you probably know, midwifery in the current climate is quite a challenge. And even prior to the pandemic, midwifery was a challenge. Our main challenge is midwifery vacancies, which is well known throughout the UK. We've also got quite a burnt out workforce who've been working very hard for very long. And we have a significant complex transformation programme within the UK, which is quite complicated, and we spend a lot of time implementing that. The positive side of that is that we've done a lot of national work about improving outcomes in maternity care, and for birth parents and for babies, we are seeing a reduction in morbidity and mortality in the UK, and that definitely it has been ongoing. So that was our challenge before we even started, and then we had a pandemic, and then on top of that, in the UK, we've had a lot of very difficult reports published around care in maternity services. So I wanted to talk about delivering maternity care in a sea of change, and it is like a lot of services where things are changing all the time. So many of the recommendations from the reports that we have are large. There's many of them. Some of them are for internal organisations to implement, and some of them are national agenda that need implementing. There's been a lot of negative press around maternity care, and that affects both service users, so families that are accessing services worry about maternity services, and also for the staff. They find the negative press quite difficult to deal with. So no matter what, we have managed to keep our services running, even though we are seeing all these challenges. And we've spent a lot of time assuring families and trying to maintain good experiences for women and families. We are seeing some changes in outcomes, and we think these are related to COVID-19, but we obviously are very early in days around that, and there's some work going on both locally, nationally, around that. And we have continued, no matter what the challenges are, we've continued with the transformation programme, and that's why we're still seeing the improvement in the outcomes. And we've had to be really, really adaptable all the time. What we also are seeing, particularly in Doncaster, is an increasing complexity in maternity services, and many of our birth parents have complex needs for various reasons, and certainly we have a high population of women that have diabetes in Doncaster, and with the increased complexity means there's increases in care requirements, and it's not only for diabetes but for a lot of other conditions as well. So this increases the care requirements, which translates into more appointments being required, more scans being required. There's more hospital attendances, and often there's more emergency attendances. And what we're also seeing is that the number of birth parents that are needing to be induced earlier is increasing. And that is following the national guidance that we've been given, particularly around diabetes, to induce by 38 weeks. So that's quite a big change for us. So amongst all this sea of change and challenge, we obviously our absolute key focus is to keep everyone safe. So we spend a lot of time utilising our resources as best we can, whether that be staff, space, or how we deliver services. We're obviously following national guidance all the time, and that is changing. We spend a lot of time doing dynamic risk assessments because particularly within maternity services, most things aren't risk-free, but we have to balance the risks up. And we spend a lot of time listening to families, and though obviously the national reports have given us very, very clear indications of how families have experienced services previously. We're constantly learning. So again, national reports, then we get into a more local feedback around Maternity Voices partnership that we work with, and also around our complaints and our compliments as well, because we get a lot of positive feedback. We spend quite a bit of time accessing funding, and we're quite lucky within maternity services that there are often pots of funding that we can access for specific projects. And we also spend time using or looking for opportunities to work with other services to support the maternity service. And so to the future, I think we definitely within the UK are obviously looking to increase the number of midwives, and there's lots of things going on around that, including international recruitment, changing the way we educate midwives, a lot of work around recruitment and retention of midwives within the UK. We look at all different options, and can we deliver things differently? Is there another way of delivering our maternity services? We're always looking to utilise talents from other roles, so whether that be nurses, maternity support workers, local services, or peer supporters. And we spend a lot of time looking at what other options have we got. We definitely have used digital solutions previously, and during the pandemic we had the Hampton trial where we monitored ladies with preeclampsia at home. They took home a BP monitor. We've also secured funding and been part of a trial with women with digital monitoring of their glucose monitors. So we have implemented that, and we have seen the benefits of that. I also think there's lots to look at around home monitoring. That definitely is a way that we need to look at how we can deliver services, and also looking at delivering things more virtually. Certainly we did that during the pandemic. A lot of our community visiting was done virtually. So that is definitely another area that we could explore. And that's the end of my presentation. So thank you, and I will pass you on to the next presenter.
Thank you very much, Lois. That's super. Some good insight there into the challenges that you're facing. Next, I would like to introduce you to Mary Brosnan, who is the Director of Midwifery and Nursing at the National Maternity Hospital in Dublin, Ireland, to explain how they have used digital health in the past or are still doing so. So over to you, Mary. Thank you.
Thank you, Jo, very much. Good morning, everybody. Can you see the slides yet? No?
That's it, Mary. Yes, thank you.
Very good. Thank you. Good morning, everybody, and welcome to the webinar. And thank you for asking me to speak, everybody. My name is Mary, and I'm the Director of Midwifery here in the National Maternity Hospital. It's one of the largest hospitals probably in Europe. We have over 8,000 births every year. And everything Lois said, I can relate to in terms of the challenges of working through the pandemic and trying to adapt our services to keep everybody safe. So I'm going to just really share a little bit of the work that my team in the midwifery diabetes team have done around introducing virtual gestational diabetes monitoring clinics. And it's been one of the things I think our team are very proud of. So I'm delighted to just share this. And this is on behalf of, I didn't do any of this work, I must tell you, I just support them. So my team are Ciara Coveney, Emer Rutter and Sean O'Callaghan, and they are an amazing group of people. So just to give you the context of, that's the hospital at night time. We're right in the city centre, and it's a beautiful old Georgian building, and we are hoping to move to a purpose-built maternity hospital that's co-located in the medium term, I hope. It's a long running saga for us, but I won't go into that today. So just an overview of the service, and again, Charlene mentioned it, and we have, last year we had almost 8,000 births, so 844 women referred for diabetes, which is over 10%, which is again a big rise we've seen in the last number of years. I remember when we had 400 women with diabetes and we thought we were beginning to get very overstretched, and now that number has doubled in the very recent years. The vast majority of them, as you know, will have gestational diabetes, so that's almost 10%, and 64 have pre-existing diabetes. So RAMP stands for the Registered Advanced Midwifery Practitioner. So Ciara is our AMP, and she has, in the first weeks of the pandemic, she approached me and said, we really have to do something radical, Mary, because these women are not able to come to the clinics. We're reducing our footfall, and I have found some really interesting technology that I think will help us. So when we suspended the in-person clinics, we at that point had nearly 100 women every week coming in to various stages of the clinic for monitoring. So Ciara and the team immediately began to look at how we could do a phone line service initially and virtual education for women. So that was quite quickly. But then she discovered this technology through her own initiative, really, on a Bluetooth technology. And so she approached the diabetes medical team and the endocrinology team to say that she thought this would be a very useful initiative. And so what we do now is almost all of our women are seen for most of their visits virtually. The diagnosis is made by, obviously, at the clinic, but then when they come to the first telehealth consultation is involving and discussing the diagnosis. There's a virtual lifestyle education class and an understanding of an explanation for women about what diabetes, gestational diabetes is. And then they're brought to a virtual clinic, and I'll explain that in a moment. So I wonder, could I just move that over a little bit? Jo, can I move the slides across over a little bit easier? Can somebody do that for me? So this is just to show, so every woman is asked to come to a virtual lifestyle education class. You can see in the top right-hand corner, that's Hannah, one of the midwives who's currently on maternity leave, is directing the class. But she's explaining this whole physical activity chart for women and explaining what it is about lifestyle management and taking control of their own condition, which is proving to be a really, really important element. And Charlene already referenced that. But I think this is one of the most important things, is giving women the tools to manage their own condition. The next slide here shows you around the Bluetooth enabled technology. Again, it's such a simple cloud-based technology that we use, and women are encouraged, shown how to use this. It's really simple. Most people are reasonably well able to adapt to this sort of technology. And if they have communication challenges, or if English isn't their first language, more time is spent explaining this technology to the mother, to the woman. But again, it's proving to be extremely beneficial and really simple. And if you look at this, you can see on the app, you can see the high pattern is shown when the person has 3 or more readings on different days, that shows it's high, and the low pattern, self-explanatory there. And so it gives the woman control, and it gives the midwives the information is downloaded then into the woman's chart here in the maternity hospital, and she then can they have that consultation with the woman, explaining what interventions are needed to change her treatment if that is the case. So obviously, there's no doubt we've saved quite a lot of money with reducing the number of unnecessary testing we were doing, and so I'm not quite sure we achieved the 100,000 savings, but I'll take Ciara's word for that. I hope we did. There's no doubt about the patient satisfaction and engagement. We've had enormous improvements in our DNA rates. Prior to the pandemic, we were probably bringing women to the hospital most weeks, or certainly every second week. It's a big trek into town if you live outside of the city. It's congested city centre hospital, as you can imagine. Like most city centres, traffic is difficult, and we were dragging women in, often with small children, 2 or 3 tons a month sometimes. So this has really reduced the footfall. A big part of it has been reduction in waiting times for women. We generally don't have diabetes waiting lists in pregnancy naturally, but I think that just means we are really much more responsive in our approach to talking to women and seeing women. At the moment, and I don't have the findings yet because we're at data analysis stage, but the team have looked at 600 women and retrospectively looked at 300 outcomes before the pandemic and how women were responding to the gestational diabetes treatment, and then 300 women that they've cared for since this intervention. And already the early analysis is showing that there's been no reduction in care, and in fact an increase in the engagement that women are having with the service. So that would be a very important piece of research, and I hope the endocrinologists won't be upset to think that the outcomes might even be slightly better with the interventions with the midwifery care here. And I'm just being facetious here. The last couple of slides here, what we've learned, I think the team really feel that the classes have to be interactive. There's no point in sending a woman a link and just telling her to watch a screen. If they see somebody on the other side of the screen, that's been the huge benefit. So people are feeling that there's somebody actually listening to them, as opposed to going to a chat box or going to watch some online classes, that there's no interaction there. Again, we did find that there was a high DNA rate in the beginning. That had probably a lot to do with everybody getting used to using technology. But we used the text-based reminders. That's been really helpful. And again, the virtual service has been, we're using a platform called Attend Anywhere. I think the NHS use it also. So Attend Anywhere has just been fantastic, because you can have 3 or 4 women, 3 or 4 people, I should say, in the consultation. It's a video-based consultation, so the woman can speak simultaneously with the midwife, the dietitian, the physicians when they need to be there, the maternal medicine specialists, and the endocrinologists, and also our administrator is involved. So it's a really that technology has been really a game changer for us. I think the other thing to say is accountability for the woman for her own care is obviously, it goes without saying for every aspect of maternity care, but for this too, women do need to engage. They do need to know that there's a health professional there with them, and I think that's the difference, as I said earlier, about just sending somebody a link and telling them to watch this video. And the changing workflows has been challenging, there's no doubt. There's been technical problems, operational issues, a lot of maternity leaves within our own team, as it happens in the last 2 years. and a large amount of adaptation of the entire system. I'll just have one more slide to show you here around a lovely model, a change manager model, just where we started with. Obviously, we were at doing things the same for many, many years, bringing large numbers of women to busy, crowded clinics where they really didn't find they had a whole lot of time. How the team introduced this change was really to engage the stakeholders, and I suppose that everybody was slightly worried that this was going to be a step too far, and it was a step into the unknown. And would women's outcomes dip? Would there be unintended consequences? And we found, thankfully, that hasn't been the case. The "are we there yet" stage, there was a huge amount of GDPR issues, managing with clinical risks, setting up protocols, policies, convincing the wider medical team that this was going to work, and dealing with all the software problems, because that was very, very difficult, as anyone knows, in the early stages of the pandemic. A lot of staff training was involved, a lot of requirement for the midwifery staff to step up and really take ownership of this interpreting clinical data, which was a big worry for them in the first number of weeks, particularly. I don't think we're ever going to go back now to the old days of large numbers of people sitting in busy antenatal clinics. I think for this particular cohort of women, it's really, really showing to be extremely beneficial. And I think it's shown us that we can move to new ways of working. Laura's mentioned a lot of other areas that has had to adapt in maternity care. I think this has been a very positive adaptation, and I think we're going to have the evidence very soon to show that. And the last slide, I just want to again credit the team who did this: Ciara Coveney, Emer Rutter, I should say, and Shona O'Callaghan, who are a terrific bunch of really motivated midwives that I'm delighted to have on the team. So if anybody has any questions, I'm very happy to take them, and happy to be part of today. Thank you.
That's super. Thank you, Mary. Yeah, we'll have questions towards the end. Hold on, let me just see. So I'm going to introduce you now to Aisling Geraghty, who's our project clinical trials manager. So she's going to give a little bit more on the features of the interventions, digital features of the intervention. So over to you, Aisling.
Okay, thanks, Jo. Great. So I suppose a lot of the theme throughout and what people working in the area will be aware that prevention is key in trying to intervene as early as possible to improve outcomes for both mother and baby. So that was quite important in the project. The aim is prevention and then support after. So as Charlene spoke through about the project itself, it's sort of built in that we're trying to identify women as early as possible, women who are at risk of getting gestational diabetes, so that we can support and intervene early as possible. So the tool that we're using is the Monash GDM screening tool. So I know Charlene spoke a little bit about it, but how the tool works, it uses sort of known risk factors and factors that are collected routinely in hospitals as well. So it's based on, it applies a scoring system. So it's based on age, ethnicity, BMI categories, whether the woman had GDM in a previous pregnancy, and if there's a family history of type 2 diabetes. So the aim of this is to apply a score to identify women who are at risk. So as opposed to screening someone for GDM, they're screened for their risk. So we use a cutoff of a score of 3 or higher, which indicates that this person is at about a 30 to 40% increased risk of developing GDM in their pregnancy. So this tool has been compared to other models, other risk screening tools as well. And it's been, I suppose, scored as one of the best first trimester models. So this was picked as women attending the hospital generally near the first or the end of their first trimester. And so I suppose it was identified as just one of the highest and the best screening tools to identify this group of women. So in our project, we use this screening tool in all of our clinical sites for all women attending the maternity hospital to try and identify the group that will benefit most from the intervention itself. So then just what the intervention itself involves. Well, this is an mHealth program, and as Charlene was saying, it runs from pregnancy, so from when the women are signed up generally near the first end of their first trimester, up to 12 months postpartum. So it is approximately 18-month duration in total. A lot of work went in the start into designing the intervention and making sure that it works for this population as well. So there were reviews of 36 different trials looking at various areas to make sure that the penetration level is high, that we're getting the right group of people. It was important to look at how this intervention was going to be delivered. Even as Mary was saying, who delivers an intervention is very important, and how it's done. And the content as well is really important in an intervention. And we were looking at, there's been a lot of research looking at lifestyle interventions that have worked, and a lot of work was put into seeing which aspects actually work. So looking at behavior change strategies and the content that have been shown to be evidence-based. And then as well, looking at the population that the intervention was for and making sure that it was designed with them in mind. And previous research has shown that digital interventions are quite acceptable in populations at risk and with GDM as well. So then this study was also based on previous interventions during pregnancy and postpartum. So rather than reinventing what's out there, this was based on trials that had digital aspects, but that were designed to support women at risk for additional support for around weight management and gestational diabetes and type 2 diabetes. So with the Bump2Baby and Me intervention, we sort of took the best aspects of all of those trials and what participants have previously fed back was important to them. So aspects like personalized goal setting, having push notifications, being able to kind of report their own progress, the intervention, the app, or I suppose the digital intervention needs to be easy to navigate and based in behavior change. And then there were different aspects around kind of group functions and to be able to connect with healthcare professionals and other women. So all of this was sort of packaged into one program. So this is the Bump2Baby and Me app and health coaching program. So this is with our partners in Leva Healthcare. And how this works is there is a trained health coach that is, I suppose, running the intervention. So these are all healthcare professionals. And they support women throughout pregnancy to birth and up to the first year of life. So they provide tailored support at the right time for the woman and for their baby then. So the health coaches guide the woman throughout the different stages of the app. They personalize content. So this was based on their specific needs. They're able to provide specific information, but also at the right time. So I suppose giving a kind of an overview of the different aspects of the app, there are 5 different features. And this allows, I suppose, the health coach to provide support in different ways to suit individuals as well. So, and if the first feature is a synchronous coaching session, so this is a live video call that the participant can meet their health coach and kind of build up that rapport and set personalized goals and get to know them. So this happens twice. So at the very start of the study during pregnancy, but then also postpartum. So just after they've given birth, around kind of 6 to 8 weeks after that, they have another call. And this can be to adapt goals or just to discuss, I suppose, what the changes since they've given birth. And then the second feature is an asynchronous coaching. So this is a combination of text and video messages through the app itself. So the person can speak to the health coach, can send messages, can send video messages. And the timing for this, so sort of changes throughout the intervention. But the idea is that they kind of bridge that care that they can communicate in a way that suits them. And the third feature is sort of push messages, and this can be kind of checking in or I suppose sending links to different content this way. There's the online education or kind of support resources, so like a library with different resources on information, and these can be pregnancy based, but also for the child as well. So the person can log in and check these, but also the health coach can direct them to specific resources this way as well. And then finally, there is a virtual social network where the participants can communicate and speak to each other through the app as well. And so this is what it looks like. This is through the Leva platform and the app. So all the coaches have been trained in behavior change, and they can set personalized goals. So with weight management, it is multifaceted. So the health coaches can guide them, but the participant themselves sort of set what sort of goals they'd like to set for themselves, and they can kind of log these within the app. And then there are the different resources on various different topics. So this can be like sleep or physical activity. If they do develop GDM, there's different resources for that. And then also resources for afterbirth around feeding practices and postpartum health as well. So then the next steps in the project. So as in the research project, our primary outcome is maternal BMI. So looking at the change between the intervention and control arms at 12 months. But there are a range of secondary outcomes that we're also going to look at in terms of weight management and the mother's metabolic health during pregnancy, whether she developed GDM or not, diet, physical activity, sleep, various different kind of outcomes that we'll be able to look at when the trial finishes. But within the app itself, and there is a team working within LEVA and within Copenhagen University who's looking quite more detailed at the use of the intervention and the use of the app. So within, it's all anonymized, but we'll be collecting information around the use of the different features. So I suppose uptake of the asynchronous calls or the use of text messages and the interactions with the health coach. And we'll be able to look at the use of the resource library or which resources maybe were more popular and usage of the app in comparing pregnancy and postpartum use. We also collect information on all of the different aspects. So we'll be able to look at the cost analysis to see, I suppose, the cost of this compared to the outcomes and then how sustainable that will be. So there are, we have 2 health coaches in each country working on and supporting this, but when it is, I suppose, at its max, one health coach can usually quite comfortably manage up to 200 patients. So so it's quite a feasible amount of people that it can be done in this way. So as Charlene had already said, we have the timeline that we're hoping to be able to, sorry, I'll put all these up. We should be finished with the data collection. We finished the pregnancy stage, and at the moment we're collecting all of that data and cleaning through it and hoping to start looking early next year. But the last participant will finish around September last year, and we'll be able to look at the outcomes of the trial and also the use of the app and how that works. So we are hoping that through this design, it will, I suppose the intervention is designed to support more women, but also provide information at the right time. And this is designed to work alongside routine healthcare to support more women this way. So we can follow along with the journey. We do have the website and the Twitter page and all the information and updates we also post there. So thank you.
That's great. Thank you, Aisling. And once again, thank you very much for all the speakers for sharing your knowledge and information this morning. I found that very informative. Thank you. I'd now like to open the floor to any questions for our speakers and also to invite an open discussion and see whether there is anything else to discuss. I've put a few kind of questions on the screen there, but I'm going to stop the presentation sharing while we have our questions. So if you do have any questions, please put them in the chat or raise your hand. There's the hand emoji, which is the reaction button at the top of your screen. And please feel free to talk. Just let me stop sharing. Okay, so there was, I noticed in the chat there was a comment from Belinda, how I think it was when Mary was talking about the intervention, saying how you loved how you start with education, exercise education first rather than nutrition, which is the focus in Australia. And then Belinda asked another question. It was actually when you were talking about the Monash risk screening criteria. I think PCS, so is it PCOS ovary syndrome, something like that?
Yeah. What? Sorry, the question?
It was PCOS not included in the Monash risk screening?
No, it wasn't. It is included in some other screening tools, but it's not within the Monash GDM screening tool. So polycystic ovarian syndrome is the PCOS. No, it's not.
Is that a risk factor? Is that why that question was, Belinda? Yeah.
So it is for some tools, they sort of weight it slightly different. This one doesn't though.
Anybody else got any questions? I can't see any hands up. Okay, is there, oh, hold on, we have some here. Yeah. Okay, so how different sites experiences for the women using the chat forum groups? Anta, would you like to raise that question yourself?
Yeah, I can comment on that.
Okay,
the chat group. So we had the virtual, I suppose, interaction. It's quite varied. Now we will be looking at that, and we want to look at use within pregnancy and postpartum. I don't think it has been as popular as we thought. Particularly at the start, the project started in the Dublin site first, and the use was quite low. But we will be looking at that soon, just to see whether that feature was as useful as it was. But I think the use of it was lower than we had thought it was. So, yeah.
Okay, thank you. Anybody else?
Can I just add, I suppose, it's been a bit of a common feature across other interventions in this space, that the uptake of chat forums within app-based interventions, that the forums or the community spaces haven't been as well taken up as have been proposed by the design part of the when you're doing the sort of co-design piece. A lot of the time it's what the groups that say they want a community created for them, and when they're saying this is what we want in this space, and when you actually create it, the uptake tends to be variable, from what I can read, and particularly in this group. So it seems to be that it's what you're being told in that kind of co-design piece, but the actual uptake tends to be, I think, it's grass is always greener on the other side, I think, in a design environment, is what I'm reading in the literature, in a lot of studies, in this group in particular, it seems to be.
Thanks, Charlene. We had another question from Belinda. How is it going for the CALD population? I'm afraid I'm not sure what that acronym means. Maybe Charlene, you look as though you've taken your mute off.
Yeah, so that's culturally and linguistically diverse groups, CALDs. Yeah, we, in terms of the different countries, we obviously have different sort of penetration rates within the CALD populations. So it obviously varies across the different countries. I would say our most diverse populations are within the Australian cohort, but we do have a relatively, diverse population for each country based on the country itself, and the type of GDM population that they have, because of the nature of the populations that are in each country. So you don't expect to see a very diverse GDM population, say, in Spain, because that's the nature of the population that they have within that country. So the GDM populations that we have in each country are, from what we can see, reflective of the populations that we're expecting to see. Does that make sense? So in terms of engagement, we haven't quite gotten down to looking at that data yet, is really what I could say. I don't know, Aisling, do you want to add anything there?
We're just getting that information now. We've been looking at ethnicity across the sites within each site, and yeah, it's more variable in the Australian site, but I suppose as we were expecting, just based on the risk factors, based on the screening tool and known risk factors for GDM, but we will be able to look through, and we will be looking at the impact of that with the outcomes as well, hopefully early next year. So, yeah.
Thank you. Could I just ask, kind of Mary, Lois, or anybody really, do women are they quite comfortable or expecting to see kind of digital interventions in healthcare now? Is it kind of, I suppose if you kind of go, when I had my kids, I'd probably went, oh no, not sure what to do with these systems, or is that kind of evolving as the younger generation kind of accepting that a little bit more?
I mean, I don't know, Mary, if you want to go, I want to go up. From our point of view, we have digital records anyway, so our families have access to their records on their mobile phone anyway. So, and certainly when we've used digital solutions before, it's been quite successful. Mary, I don't know what your thoughts are.
Absolutely agree, Loris. It's we have the electronic patient record too, but we don't have the patient portal, which is a big failing so far. It hasn't been invested in yet. But absolutely, I think the other thing we did at a more general level during the early days of the pandemic was revert to antenatal education. For all of our education was remote, and it was absolutely terrifically successful. Again, probably due to the people who developed the program, but breastfeeding has a lot of our interventions have become virtual through that, and it's been really, really positively received. And I think it's been a leveler, in fact, because often women can have their partner there in the background, they can have their children in there. It doesn't really impact on their day-to-day life. They give that 15-20 minutes to what they're going to do, and they don't have the commute. So I think it's the way we have to consider a lot of our workload, our working lives, I think.
Yeah, I think virtual definitely seems to be the way to go forward. The uptake tends to be better, like Mary says. You know, we've done breastfeeding support through a virtual forum, and that's definitely been popular.
Okay, thank you. We have a couple of questions and that came in first. So, were physical activity levels at baseline considered? Is that an Aisling question, maybe?
Yeah, we collected all that information. So at the start, when all the participants in both control and intervention arm initially signed up, we collected information on baseline physical activity, baseline diet, sleep, mental health, well-being. All of those were collected, and we're going to collect them again at the end of the intervention. So we'll be able to compare change from baseline, not just the differences between groups. Yeah.
Thanks, Aisling. And then there's another question in the chat before I move on to Anta. There was most of the population thinks that GDM is a disease that appears in pregnancy and disappears at birth without taking into account the possible future problems for mothers and babies. Don't you think this is one of the biggest problems in dealing with the prevention of GDM? How could effective communication for GDM prevention be done? But thank you for that question. Does anybody like to take that one?
Well, I'd just like to put in a thing here, and then I think I'd really like to put it back over to both, I suppose, Lois and Mary. I think one of the key things that we're trying to do with Bump2Baby and Me that came to us when we were writing the grant was trying to create a connection between pregnancy and the postpartum piece, and seeing that as a key moment, that it's part of that journey. It's a continuum, and we wanted to create a connection between those two things so that the woman felt that there was a journey happening rather than being, you know, a lot of the women talked about being dropped. And so we wanted for them to feel like there was some continuity of care happening. And so we were trying to create a bridge. And so that was one of the key things that we were trying to do with Bump2Baby and Me, was create a bit more of a bridge between services. And so one of the things that we did implement within Bump2Baby and Me, and perhaps we didn't flag it within the talking about it, we implemented another virtual consultation that the mums have if they get diagnosed with GDM, and they have another consult that sits alongside their care, and we actually talk to the care system so that the women feel they can use it if they want. They can have an additional consult with their health coach and to say, I've had GDM diagnosed, so that it's complementing the care that they're getting in hospital, so that when they have their postpartum you know, consultation, that they're additionally getting sort of more continuity of care, I suppose. So I don't know, Mary or Lois, do you want to talk about that kind of piece? Because that's one of the key things I suppose was central in our minds when we were thinking about it, trying to complement the system that's there, because we know we can't fix a system, and we were trying to create a bridge.
Yeah, I suppose the only thing I'd say is in Ireland, our healthcare is quite fragmented from hospital to community. So I remember when I worked in the NHS, there was a lot more streamlined intervention or integration with health visitors and the whole community health system. unfortunately, I would say that's still a bit of a failing in the Irish system. We discharge women, we see them for the first 6 weeks. We don't see them until they're pregnant again if they come back. And we do, and I think the benefit of the whole emphasis on gestational diabetes is around the lifestyle of the woman and her family, and trying to take the guilt out of it, trying to take the judgment out of it, but trying to make somebody realize that pregnancy is the one and only opportunity sometimes to influence a family's lifestyle and a family's future health. So I think that's the benefit of management of gestational diabetes, breastfeeding, all of the things that we take for granted as our bread and butter. But I think that's critical. And Lois has a probably very similar perspective, but
yeah, I do. I mean, you're right. In the UK, we're quite lucky, and particularly in Doncaster, there's a lot of work going on with the council, schools, health visiting. When we're doing a lot of early years intervention work, prevention work. We won't obviously see the benefits of that for a little while, as you would imagine. But we've also got a research project called Baby D that we're currently running as well, and that's looking at health outcomes for our women who are currently pregnant, and we'll follow them and their families right the way through. So we've just commenced that this year, and that will run similar to the Bradford project, if anybody knows that project. Exactly the same for us, but we've obviously very new into that. And I think Kerry, one of our research midwives, is actually on this call, but she's instrumental in doing that work, and that will help us. I think, prevention is definitely the way forward. It just takes a bit longer to implement and see the benefits of.
Thanks, Lois. Antje, I think we've just got time for you to raise your point.
Hello, I actually wanted to ask something.
Okay, thank you.
And actually two things. I'm one of the PhD students with Timothy Skinner, and I am looking at the synchronous video interactions. And I have a question because I'm curious. I'm listening to so many women now, and they are so differently informed about what this is about, the project. And I wonder, what is the information level? I'm just curious for the project. What is the information level before they are enrolled? And unfortunately, I'm only listening to the Irish and the English because there's no video data from Australia. I'm sorry, but otherwise I would have also have an impression of that. But these two cohorts, I can't really understand what do they know before. And the other question, whoever is going to answer, is an academic one about the manual the coaches are using. Is it something we in academia are allowed now? I am allowed now to lend to a student to look at how is it implemented actually in the interactions. How do the coaches use the manual in a more, Slavic, or I don't know how to say, in a very in a scheduled way. So and if I am allowed to use it, who am I to ask to hand it over to a student and so on?
Thank you. I think that Charlene, you could just quickly answer. It might be one we can take offline with you.
Yeah,
as well.
they're all quite applied questions, Anja. We might actually answer them if you don't mind. We might take them offline because I think we've run out of time.
Oh, so, yeah, okay, of course.
Time to answer them here.
I can I'll add it just quickly. We are looking at, I suppose, women's understanding, and because when they're recruited, there's quite a lot going on at their first visit in the hospital, and that's quite a focus. I see Mary Alvarez is online as well, and she's quite interested in that area and women's understanding of research and what they're signing up for. So it's planned to be part of the analysis, that women understand why they were involved in the project or why they're at risk in that area. So, but otherwise we'll follow up with you offline.
Yeah, absolutely, Anja.
Okay.
We drill down into that. I think it'll take probably half an hour.
Okay.
Okay, thank you very much for that. As we said, we've gone slightly over time, so apologies for that. Just a few points to wrap up. So thank you once again for everybody for presenting and for asking questions and spending the time to listen to us today. Going forward, we would love for you to keep in touch with the Bump2Baby Me project, and you can do this by coming to our next forum meeting, which is planned for the 19th of April. We don't have a topic for that currently, so if anyone has anything they want to find out about or would like to hear about relating to this topic, please do let us know. You can also follow us on Twitter or LinkedIn, and you can subscribe to updates via our website. The link is there. And if you wouldn't mind, Claire, my colleague, has put in the chat a form to complete. It's very, very quick and simple. It really is useful for us to kind of assess how these meetings work and get some feedback, and so we can develop them further in the future. So thank you very much for everybody's time. We look forward to seeing you at the next Bump2Baby Me Forum. Enjoy the rest of your day. Thanks all. Bye.
Bye-bye.